Thank you, Stephen. And I want to thank the organizers for the opportunity to be part of this imaging-focused webinar. So today I'll be talking about the role of strain imaging in cardio-oncology. Here are my disclosures. And I want to start, before I start, I want to acknowledge our sponsors for their support of this program. So in the next 20-25 minutes, I would like to provide an overview on myocardial strain and speckle tracking echocardiography briefly. I'd like to discuss the clinical utility and application of strain imaging and present several cases to demonstrate the utility of strain in cardio-oncology. And then end with some practical guidance on how to implement 2D strain in clinical practice. So strain is a dimensionless parameter representing deformation of an object relative to its original length, calculated as the difference in length before and after the force is applied over its original length. It has been used to describe the elastic properties of cardiac muscle, and in the myocardium, strain measures its length in diastole and systole, and serves as a measure of contractility. So if the fiber starts at 10 centimeter and shortens to 8 centimeter, strain is minus 20%, as according to this formula. And if it lengthens to 12 centimeter, then strain is positive 20%. And if no change, then strain is 0. So 2D strain is obtained via speckle tracking echocardiography, which is a grayscale-based technique. Speckles are natural acoustic markers generated from ultrasound artifact as a result of scatter of the ultrasound beam by the tissue. The image processing software identifies these speckles and tracks a user-defined block of speckles or region of interest, frame by frame, throughout the cardiac cycle. And by computing its change in motion, it derives magnitude of myocardial deformation in different directions. Now, there are several advantages to 2D strain imaging. It uses the standard grayscale images obtained on routine transthoracic echo, so additional imaging is not necessary. It has good image quality with good signal-to-noise ratio, and in theory, it is angle independent. It has ability to measure strain in multiple LV segments from a single acquisition, as well as its ability to measure layer-specific strain at the endo, mid, and epi level. And the availability of automated post-processing software streamlines GLS measurements such that user input is minimal. There are limitations to 2D strain imaging in its current form. The accuracy of strain measurements is dependent on 2D image quality. The high reproducibility is established only in global longitudinal strain. The reproducibility or reliability of segmental strain values have not been established. And 2D strain is unable to track speckles moving out of scan plane of the 2D image. And probably the most important limitation currently relates to the vendor-specific speckle tracking techniques, such that strain obtained on two different systems are not exactly interchangeable. Further, strain data stored in proprietary scan line format are not analyzable using another vendor software, creating much workflow issues in multi-vendor lab. Now, 2D strain permits the assessment of the three principal components of strain. Longitudinal strain denotes shortening of the LV along its long axis. Radial strain denotes thickening of the LV wall along its radius. And circumferential strain depicts reduction in the circumference of the LV. Now, the mechanistic properties of the LV bears impact on the pathologic effect of various conditions on LV function. So briefly, the myofiber geometry consists of longitudinal fibers in a right-handed helix in the endocardial layer, transitioning into circumferential orientation in the midwall, then becoming longitudinal again in a left-handed helix in the epicardial layer. And with regard to function, the mid-myocardial and subendocardial layers govern the radial, circumferential, and rotational mechanics, whereas the subendocardial fibers determine predominantly the longitudinal contraction. Such that the subendocardial layer is often most sensitive to disease and often first to be affected. Thus, longitudinal LV contraction often serves as an early marker of LV dysfunction, often impaired before circumferential and radial function deteriorates. Now, global longitudinal strain has been shown to be sensitive for assessing myocardial function and detection of subclinical LV dysfunction, and it is most commonly used in clinical practice and considered the clinical standard for deformation analysis. It has been shown to be most robust in terms of reproducibility and shown to be superior to 2D ejection fraction with regard to reproducibility, correlation with MRI-EF, and prediction of overall outcome. Now, multiple studies have shown early reduction in GLS predicts subsequent drop in LVEF during cardiotoxicity treatment, supporting the role of GLS as an early marker of cardiotoxicity. And studies have shown that absolute GLS at baseline and during therapy, as well as relative deterioration from baseline, have shown to be predictive of subsequent cardiotoxicity. And according to the ASE EACVI document, a drop in GLS by 15% or greater is likely clinically significant and indicative of subclinical LV dysfunction. Now, among the cardiac MR and echo indices for assessment of LV systolic function, cardiac MR, LVEF, and echo GLS have been shown to have the optimal temporal and observer variability, such that in the absence of cardiac MR, as access and availability are often an issue, echo GLS should be considered the method with the least variability for monitoring myocardial functional changes in patients receiving cancer therapy. Now, 3D strain can be obtained using 3D speckle tracking echocardiography, and studies have shown earlier and more pronounced changes in 3D EF, circumferential, and longitudinal strain compared to its 2D counterparts in patients receiving doxorubicin. 3D strain provides incremental value as it is able to track speckles within the entire scan volume, including out of plane motion, and it can be more reproducible than 2D strain. However, its application remains primarily a research tool given the number of critical limitations. Now, 3D strain was used in this study to assess RV cardiotoxicity, a topic which is not discussed often, among patients receiving anthracycline for treatment of lymphoma. And the study found that compared with 3D EF, 3D RVEF became impaired at an earlier stage. Further, changes in RV volumes and longitudinal free wall strain were associated with subsequent drop in RVEF. These findings suggest that RV may potentially be more vulnerable than LV, perhaps given its thinner walls with fewer myofibrils, as well as myofiber architecture. So now I'd like to move on to a couple of cases. So the case one is a 57-year-old woman with HER2-positive advanced breast cancer. She has a history of diabetes, hypertension, on amlodipine and hydrochlorothiazide. She's status post mastectomy and adjuvant anthracycline-based chemotherapy and is scheduled to undergo her anti-HER2 treatment. She's asymptomatic without cardiac symptoms. So her echo prior to starting treatment, EF and GLS were both normal, EF of 67%, GLS of 22.6%. And after anthracycline, before starting her anti-HER2 therapy, EF drops to 59% and strain drops to 17%. So a drop in EF of 8% from 67 to 59 and a drop of strain of 25% from 22 to 17%. So back to the ASC consensus document, This patient, based on her GLS, had demonstrated the presence of subclinical LV dysfunction. But what are the therapeutic implications of subclinical LV dysfunction by GLS? That is, can we consider abnormal GLS as stage B heart failure, warranting heart failure treatment? And this was the central question of the SEQUOIA study, a multi-center prospective randomized trial testing the hypothesis of whether strain-guided use of cardioprotective therapy will limit the development of reduced left ventricular ejection fraction. So patients receiving cardiotoxic therapy were randomized to a strain guidance arm versus a conventional EF guidance arm. And cardioprotective therapy was initiated if GLS dropped more than 12% in the strain guided arm, and when EF dropped more than 10% to less than 55% in both arms. And the one-year interim results were recently presented at the ESC, which showed that there was less incidence of cardiotoxicity in the GLS-guided arm than the standard EF-guided arm, suggesting that GLS is an effective marker of early cardiotoxicity that responded to cardioprotective therapy. So currently, subclinical cardiotoxicity by GLS can be interpreted as a marker of increased risk, predictive of subsequent EF fall, warranting closer surveillance for signs and symptoms of cardiac dysfunction. Cardiac protective therapy to prevent EF decline may be beneficial, though it's important to remember that GLS drop during treatment has not been shown to predict clinical heart failure or death, and has not been and should not be used as an indication for stopping cancer treatment. So next case is an unfortunate 40-year-old survivor of retinoblastoma diagnosed at infancy, who's been treated with high-dose doxorubicin of 450 milligram per meter square, who now presents with metastatic breast cancer. This is her pre-treatment echo. She's tachycardic, and her LV ejection fraction looks borderline at 55%. Her GLS is minus 17.1, which is consistent with borderline low GLS. So what is a prognostic value of baseline GLS? So studies have shown that a borderline, that baseline GLS can be predictive of risk in this retrospective study of patients with hematologic malignancy, that a GLS of less than 17.5% identify patients at higher risk of heart failure and cardiac death, and providing incremental value over clinical variables such as LVEF in identifying subsequent heart failure and cardiac death. And furthermore, a population in whom GLS may be especially useful are in patients with borderline ejection fraction, such as in the patient that we presented. So borderline or abnormal baseline GLS can be taken as an increased risk of cancer therapy-related cardiac dysfunction, warranting closer surveillance and optimizing existing cardiovascular risk factors. Consideration for cardioprotective therapy may be appropriate, as well as consideration for evaluation of underlying cardiac disease as clinically indicated. So this algorithm summarizes the use of EF and GLS for guiding clinical decision-making in patients receiving cardiotoxic therapy, as we have already discussed. So next two cases, we're going to shift gears a little bit and address conditions that's different than cancer therapy-related cardiotoxicity that we encounter, also encounter in cardio-oncology. So this is a 72-year-old man with newly diagnosed lung cancer. He has a history of well-controlled hypertension on amlodipine, and this is his screening echo for a clinical trial. And what we see is thickened septum of 1.5 centimeter, and his LV mass is calculated to be consistent with LVH, and his diastolic parameters is abnormal, consistent with a restrictive diastolic dysfunction. And here's his strain, his global longitudinal strain of 9.2%, which is severely reduced, and the bullseye showing an apical sparing pattern, which I think most of you are familiar with, that is consistent with cardiac amyloidosis. This echo finding led to a hematologic workup, which confirmed the diagnosis of systemic AL amyloidosis, and the follow-up cardiac serum biomarkers indicated the presence of advanced cardiac involvement, Mayo stage 3. So the take home for this is that the abnormally low GLS among patients with preserved EF certainly requires further investigation, identifying potential causes such as cardiac amyloidosis or other infiltrative processes, hypertrophic cardiomyopathy, or hypertensive cardiomyopathy. Now, GLS has been shown to be a strong predictor of survival in AL amyloidosis, providing incremental value over the traditionally prognostically validated biomarker staging system. So the next case is
Jennifer, before you go on, sorry, this is Dan.
Hi, Dan.
Thanks so much for your presentation so far. It's awesome, as they always are. But I really wanted to ask about the first case, but the second case brings up the same issue. So you show these beautiful bullseye plots of global longitudinal strain, and they certainly look convincing on these images. But if I was to, take a basic survey of all the patients that I'm evaluating, in which I get an echo, I would say at least, a WashU that are chance of seeing an image like that out of 100 patients, I would say it'd be under 10, to where you have such a nice profile and a bullseye plot and everything else. And so in your, at Sloan Kettering, do you have a higher percentage of baseline echoes that have that quality of strain?
Yeah, I mean that's a very valid point, and especially as we are advocating the use of strain imaging in routinely in clinical practice. So what I would say is that we identify upfront which patients should have global longitudinal strain, and we do train our sonographers to follow a certain protocol. And I would have to say that obviously I've chosen these images for the presentation, but I would say that the overwhelming majority of, and I would say up in the order of 90%-ish of patients, we are able to get a global longitudinal strain, may not be as beautiful as the one I'm showing now, where we feel it's reliable. So I think a lot of it is training. And I will have a couple of slides in the end as practical guidance and how for those who are trying to get the strain started in their laboratory. For example, purely from, and Teresa and Jeannie can also, I'd like to, can share their experience, but, you train you have a specific protocol. We have them again, the apical views all consecutively, and no question. And what's funny that you mentioned this, because I've noticed that the quality of the 2D image quality tends to be better in patients who are specifically designated to have GLS. So I think that at least in our laboratory, that sonographers tend to pay more attention because they know how important the image quality is and how important it is to get on axis.
So then this goes to my next question. So, I mean, you answered that very well, and I wish we did as good a job as you do in terms of making sure that, there's special attention to certain echoes. But, in the way that things happen in the world, you start with a patient has, breast cancer or lung cancer or whatever it is, and their oncologist sees them and says, we're gonna get started with chemo A, B, and C, and we also need to get an echo just to check things at baseline. And so they order the echo, and the patient schedules it for a few days from then, and they get their echo, and then the EF is 51% or something like that. the patient's already gotten their echo, and the oncologist then says, uh-oh, I better have this person see a cardio-oncologist. But, you know, that echo wasn't identified as a very important echo, you know, in the process that usually happens. So how do you think that we can, you know, sort of raise the standard on all the echoes that we would be potentially interested in? I'd be curious to see how you think we should address that.
Yeah. So, you know, this is the practice will differ based on, you know, the setting that you're referring to. So it took us a while, but we were able to convince our the institution, the chemotherapy team, to actually have in the order set before they can release the administration of chemotherapy, that the nursing have to check off on the echo and the ejection fraction before that can be released. And we do have cutoffs. You know, if the EF is below a certain point, that's a red flag that they have to, then the oncologist will then have to sign off, and they have to sign off and before proceeding with giving chemotherapy, because it's a problem. And we've had some, as you said, you know, we've had some patients that have slipped through the crack, and you know, they didn't recognize the echo and so on, and the patients were not optimized before starting chemotherapy. So it took some time and effort, but we have been able to embed echo result, namely EF, and before they can release their chemotherapy. And we have found that to have minimized these near misses.
And then Teresa and Jeannie, would you have any other additional experiences that how you deal with that? Both the identifying the echoes of interest, but also just making sure that, you know, if a patient who's about to start chemotherapy, you know, they're not necessarily going to be identified as a person of interest when they get their echo. So
one of the things that we were able to do is a little bit of a variant of what Jennifer was saying, is that you know, we have it in the echo order for physician order entry, whether this patient's going to get chemotherapy or whether the patient has cancer, and that, you know, that translates into you know, on the requisition that the sonographers will see that, and so that's their clue that, you know, that we're interested in strain, and we actually don't get much more specific than that, because I think that it gets a little complicated. So just try to keep it very simple. You know, even for situations where we're not expecting strain to change necessarily, depending on the cancer or the particular cancer therapy, it's more complicated for them to try to vet that out. So it's a yes, no. The problem that we have in our lab, though, is although we have that, it's you know, that there's so many barriers to you know, I shouldn't say barriers, but there's so much burden of using electronic medical records and order entry that we're trying to minimize the number of mandatory clicks. So it's not a hard stop. So when somebody's placing the order, you know, that there's a checkbox, does this patient have cancer, but you can still sign the order without checking the box. And so so in our institution, that's something that we would like to see change. And, you know, we're trying to ride that balance between, you know, having too many check boxes for someone to order an echo, and actually being able to capture all the patients that, as you mentioned, Dan, are relevant patients that are, you know, important echoes for strain.
We also have some check protocol when we receive an echo. It's probably not very specific, but it distinguishes which is a baseline echo or a follow-up echo invitation during cancer therapy, or an echo that is asked because the patient is in a clinical trial. So there is a specific protocol for this trial. And what we try to do is to scan this patient with some equipments that give us better image quality. And I think that our experience is very similar to that Jennifer explained. We are able to quantify a strain in around 85–90% of patients, because we want to acquire images to quantify strain. What is more difficult is if you try to analyze a strain from 2D images that are not acquired or a quantified strain, because probably you are not so careful in the ECG registry, in the apical view, or in the lateral wall, that sometimes it's quite difficult to scan in some patients. But if you want to measure strain and you organize a dedicated scan for that, I think it's quite easier to have good numbers.
Right.
So, it's Joe. I just second what Dan said. Even in the lab that we have, your independence really good. There's a problem with image quality and strain, but even a bigger problem is seeing people from the outside, where decisions are made or patients are sent because of abnormal strain that is totally worthless. So it's not only what we're doing, the community and the affiliates around that are reporting strain based on really poor image quality.
So I think what you're getting at, Joe, is that there's definitely a need for responsible reporting of strain, right? So if you have bad image quality and if you have an unreliable measurement, that we ought not to feel compelled to put a measurement in there and fill in the slot that says GLS is X, because I think that can actually be more. It can be more harmful than helpful, and I think I think for folks who may not understand the implications of these strain numbers, that's sort of a quality issue that I think needs to be addressed in a particular practice or lab. It needs to that point needs to be driven home.
Yeah, I mean, I think that if you remember, GLS is an average of all the segments. I mean, you guys know that. I know that you know that. But if you have several segments that have dropped out, there is no data for that average, and so it will automatically bring the GLS number down. And if you had 3 or 4 segments, for example, that dropped out, you may have a normal GLS in truth, and that when you do your calculation, it comes out as significantly reduced. And so I think it does have big implication if you don't have a technically adequate strain map.
Right. So I think that to absolutely, I agree with everything that's being said, but to specifically address the dropout, generally if there's 2 segments that two or more that cannot be measured, we will not report out GLS. And I cannot, and I want to just second Jeannie's comment that, just like any new technique, there has to be education, there has to be awareness, there has to be knowledge on how to interpret it. And the fact that, I think we've all seen crazy strain numbers being generated, and that, and especially now that, it is being reimbursed. So we are seeing an uptick of strain being done in a lot of the echo reports, everywhere. And I think that we need a concerted effort to educate, the community at large.
Yeah, I didn't mean to hang you up there, Jennifer, so you can go back to where you were.
No, it's great.
Good morning. This is Vlad. I was thinking maybe to wait for the end for a couple questions, but as Dan opened here this discussion point, I was thinking maybe I'll just sort of close with one of them is more a management question, and it links into your slide on GLS's risk, and where this challenge comes as sometimes when oncology would see an abnormal cardiac value, the chemotherapy would just be stopped. And that can be a challenge either at onset when the patients need to start, or during the oncology treatment. So I think that the type of guideline, for and communication with oncology is where the emphasis would be. And I think question number one then would be how do you manage and how is this sort of thinking about that proactively. And then the second question is maybe comes even before then, before this, in the sense that it is a technical question. And it's not so much if you see or if you don't see a segment, where I would say, okay, if we don't see a segment, then we don't report because we don't have enough quality. But given the curved shape of the ventricle being off axis will change the contribution of that curved wall into the strain. And it will give potentially a great strain because it's foreshortened and it will go very, very well, right? So I was wondering, how do you interpret that aspect of quality? I mean, it's almost even more challenging than not seeing something. And I think this links into what Dan was mentioning.
Yeah, I'll take a stab at it, but I'd love to hear what Teresa and Jeannie have to say as well. So with regards to your first question, with the oncologists perhaps holding treatment because we're reporting on abnormal strain. And again, that goes with education. So, we will write down that strain is abnormal, but, I work in a closed system. So there is, so there's a very easy communication. That just triggers a phone call. A discussion, and the patient gets plugged into Cardio-Oncology clinic. And perhaps, one things that I will recommend is that, perhaps for the folks who don't have who are not, working in a closed system, perhaps have a language that says, consider referral to Cardio-Oncology clinic. I think that might, but I totally second. I think the important point that you're making is clear communication with the oncologist in the echo report will go a very long way. And because you can report all these numbers, but they're the referring, they're the ones who are getting in, they have to know what to do with it. And often probably the easiest thing is, consider a Cardio-Oncology referral, that might be the best solution. With regards to the technique and quality check, I think that, folks who do a lot of GLS, we have a policy that we do not take what the texts provide us at face value. We will check for every single strain curves and confirm the value. So then that goes to, what do you consider as adequate tracking or inappropriate tracking? And there are things that we look for to see whether the underlying, region of interest is checking the myocardium, and determine whether in fact the GLS value is valid. And several of us put together a primer that kind of goes through step by step, and that's much needed, the education on how do you recognize poor tracking, how do you recognize, and a lot of a lot of pitfalls to strain imaging, that it's not a black box, that requires education.
I think to that point, I would also say, we have these automated algorithms now, and I think the temptation is, oh, it's automatically tracking, and so it's fine. We can just sort of see the number and report it out. And I think again, it comes back to, really reinforcing the quality of the data, looking at the quality of the data before you report it out, because I think that the automation is great, but it's not perfect.
This is Dinesh. If I could just add something, I think a point that Vlad brought up is very important. I really want to address this issue about use of GLS affecting cancer therapy. And I think hearing that kind of concept is a little bit bothersome, because the whole purpose of using strain is to prevent that exact thing from happening, to prevent interruption of cancer therapy, in my mind, should really be the goal of using more sensitive methods. And I agree with Jennifer in saying that education is important, because if you think of other alternatives, let's say we're measuring troponin or BNP, we often see elevations in troponin or BNP, and I think the same argument can be made there as well, because the oncologist sees an elevation in troponin and stops cancer therapy. So I think what's important when we're using any sensitive method, whether it's biomarker or GLS or anything else, that our colleagues need to be educated that these are done to identify early cardiac injury and intervene. At no cost should cancer therapy be stopped because of a sensitive marker being elevated.
Well,
Yes,
then,
I fully agree, and I think that what we need is, or we try to do is to explain to the oncologist what does it mean, the numbers that we report on our echoes. So if we found a significant change in ejection fraction or in strain, we try to summarize what does it mean. And in general, of course, we recommend to refer the patient to the cardio-oncology clinic, but sometimes, you know, a patient has a previous echo that was not was performed probably before cancer diagnosis, and there are some changes in ejection fraction or even in strain that are not related with any special issue, and depends on the variability between one echo and the next one. So it's very, very important to review previous studies before to finalize the current echo report, and to try to explain to the oncologist what does it mean, the changes that we are able to see.
the other point that I would make on ESMO guidelines, which were published less than a year ago, we specifically addressed this point and made a recommendation that cancer therapy should not be withheld based on any finding of change in strain, but rather to engage in, you know, further consultation, but not to not just arbitrarily stop therapy. So that's in the ESMO guidelines. So
as well as in the ASCO, guideline, and as well, I think that message has been, you know, repeated in multiple consensus documents.
Yeah, I agree. I think that's an important message, and thank you for commenting on that. It's pretty much something that is one of the first points to engage with if a patient is referred from an oncologist, just to understand why are they concerned about the patient not having chemo, or what's going on, and then reiterating the significance or maybe lack of significance of the data, especially as you're mentioning that many times now this is reported, but as the patients get referred between systems, I think that's where the challenge is, right? When they are within system, then there's access to the primary data, so the cardiologist can review the images and discuss directly with the oncologist. The challenge is sometimes the patients get referred remotely, and that's where it becomes a little bit more challenging. So thank you so much for your comments.
Thanks, Bob. This is Lauren. Just one logistical comment, and I'm going to echo what everybody else has been saying. But one of the things that we've done in our echo lab to help facilitate this type of communication, and as Dinesh pointed out, to prevent this like immediate, you know, stopping of therapy if there's an abnormality, is to create a drop-down menu of specific phrases for specific findings, and there's sort of gradations, like some things that are, you know, green or yellow just go in the report, other things would trigger a phone call, and we do have specific language, you know, about referring to cardio-oncology. You know, obviously, like, you know, we can't see every patient immediately on site, so it does generate a fair amount of phone calls and e-consults, which I think is, you know, clinically appropriate until we can physically see that patient. But it does give some guidance, because I do think, you know, we do educate, obviously, the oncologists as best we can, but it's pretty intricate, you know, detailed for them to really interpret, I think, on their own, you know, over time if they become more comfortable with it. But so I think, you know, giving, you know, obviously educating the echo lab itself. So as you mentioned, people don't just put in a number without understanding the implications of it. They understand, if I report this number, then it's going to go to this type of, you know, language, and it's going to generate potentially even a, you know, a phone call or a need for verification of the result, just like a new significant finding would. And so, because some of those things, you know, you should maybe not stop chemotherapy, but at least call and have the discussion if the EF drops a certain amount, if the global longitudinal strain drops a certain amount. But those gray areas in between, you know, we're able to give some reassurance and then connect them with cardio-oncology is helpful. And then we also flag from when they're ordered within a context in the oncology center, they're flagged for strain automatically and done, all go to the same machine, to be done on the same machine. So that's one way, depending upon if you have like Epic or whatever, EMR, to kind of flag ones that are ordered by the oncologist, because obviously, as we all know, and as Dan mentioned, they don't necessarily all come through us first. So.
Yeah, I think that what Dinesh said is really that I think we all agree that strain provides a window of opportunity for intervening so that we can prevent, cardiotoxicity from happening, and hopefully that message will, that will actually carry through and be implemented.
All right, so we better let you go on. We gotta. I threw up a big roadblock. Sorry about that.
No, it's great. All right. So the next case is a 64-year-old woman with metastatic endometrial cancer, starting a clinical trial with dual immune checkpoint inhibitor therapy with durvalumab and tremelimumab. No cardiovascular history or risk factors. Her pre-treatment echo is shown normal ejection fraction and normal GLS. 6 weeks after starting treatment, she complained of difficulty ambulating due to muscle weakness, imbalance, and progressive dyspnea on exertion. On exam, she seemed stable. Her labs were noted for transaminitis and a very high CPK, consistent with myositis, and as well as, obviously the transaminitis. Steroids were started, and a repeat echo was done, which showed preserved ejection fraction, though GLS had dropped to 13.9%. EKG at that time remained normal. 48 hours later, her symptoms worsened, dyspnea got worse, and she developed new bradycardia and was found to be in complete heart block. She was transferred to ICU, and an urgent pacemaker was placed, and troponin was elevated at 3.2, then risen to 7, and her complete heart block persisted despite treatment with steroids. She underwent emergent cardiac cath and endomyocardial biopsy. Her coronaries were normal, and RV biopsy showed intense lymphocytic infiltration consistent with myocarditis. So this case just brings out the another role for GLS, and that is in patients with immune checkpoint inhibitor myocarditis. Work from Tom Nealon showed that GLS decreased with the development of ICI-related myocarditis, even among patients who are normal. LVEF is shown in our patient. Further, GLS can be prognostic, that is lower GLS and relative drop in GLS from pre-treatment is associated with major adverse cardiac events in both normal or reduced ejection fraction. And important to remember that Tom showed in his earlier study that EF is a poor predictive outcome, as EF was normal in 50% of cases of patients who presented with ICI myocarditis, and 38% of major adverse cardiac events occurred in patients with normal ejection fraction. So remember to do GLS in patients who you're suspecting myocarditis due to checkpoint inhibitor. So the last few slides, I just want to kind of sum up actually. So it's perfect of what we discussed at sort of the clinical, the practical guidance on the clinical implementation of strain in cardio-oncology lab. So I think as a first step, it's really important to establish a workflow system that will allow the performance of high quality cardio-oncology studies and with dedicated technology and personnel. So some labs will designate the same system so that you don't have that multi-vendor variation, and also have the techs that are familiar with the protocol to do it so that you can get high quality 2D image and end up with good quality, reliable strain results. And also this obviously goes, that this is obvious that in order to set up a successful cardio-oncology echo lab, that you really have to have flexible appointment slots to accommodate urgent requests, because these cancer treatment schedule often is not as flexible and cannot be delayed. It's important to establish a standard cardio-oncology TTE protocol to include, which typically includes a comprehensive TTE as per the ASC guideline or as per the ACVI guideline, which should include 2D and 3D LVEF if possible, and global longitudinal strain. Follow-up focus exam for cardiac monitoring and surveillance studies can be performed, especially in light of COVID. That includes just the 2D, 3D EF, GLS, diastolic function, and RV function. And as already mentioned, it's important to consider the use of the same vendor for follow-up studies, given the potential inter-vendor variability in GLS measurements. One way of getting around that, of course, is to use a vendor-neutral system if trying to stay with the same system presents logistic issues. And this I feel very strongly about. I know that other labs this may not be as big of a problem, but I do feel very strongly that there should be strain software implemented into reading stations to allow readers to review and retrace strain images as needed. And that is our policy in the lab before we can sign off that the reader actually confirms the actual strain images. And then, of course, when you're asking for, your administration for support, important to note that strain imaging is in fact being reimbursed by multiple insurances. The cardio-oncology echo report should include blood pressure and heart rate, like all the other echo reports. It's important to state the technique used to quantify EF as well as the method of assessment. And for multi-vendor labs, it's important to specify the vendor software used for GLS measurement. Now, our laboratory, we report GLS in absolute values and include relative change from baseline. Reporting GLS in absolute value just avoids confusion when you're referencing changes. Important to establish normal reference values so that to facilitate interpretation of strain results. Now, although strain can vary by age, gender, and the specific vendor software, it is generally normal when GLS is greater than 18% and abnormal when GLS is less than 16%. And as we had talked about, I think it's important to incorporate languages to facilitate communication with the oncologist. So in summary, strain imaging plays an important role in the evaluation of various cardiac conditions in cardio-oncology. It is a sensitive and reproducible measure of LV systolic function, superior to ejection fraction as a marker of early cardiotoxicity, and may be effective in guiding therapeutic intervention to minimize cardiotoxicity. Important to have proper setup of echo lab workflow, standard cardio-oncology TTE protocol, and echo report. And then finally, education and training are much needed to increase familiarity and proficiency in strain imaging among practitioners. And to that end, we recently put together this step-by-step this primer that kind of demonstrates step-by-step in strain measurements using multiple vendors that I encourage those who are interested to review. And thank you for your attention.
Wow, that was a super fantastic presentation, and I have a high-powered panel here, so this is awesome.
Thank you.
Get opinions from all over the world instantly. Great. I think that we still have issues at the ground level in terms of many of the things that you just had on your last couple of slides. We have not overcome those hurdles at our own institution, which is a source of frustration personally. But on the other hand, I would just want to encourage others at other places that, lots of places are struggling with these issues. We want to continue to a rising tide raises all boats. So I think if you continue to improve the processes, that in the end it'll be a much more reliable marker.
You know, in some ways, I guess in some ways, I kind of see this the similar analogy with, let's say, you know, when Echo started introducing, you know, diastolic parameters. You know, it took a while before the community was able to incorporate that into the standard. I mean, this is going back, you know, decades, but it took a while before, you know, before the community at large embraced it and knew how to interpret it. So it's going to take time. It's going to take time. But what I think what is slightly more at stake is the points that have already been mentioned, that this may be interpreted by the oncology community as a sign to stop treatment. And this is definitely not the message that we want them to, you know, to receive.
Dr. Liu, this is Isaac Ray. I'm actually down in UT Memphis now, and I've worked. Hi there. And I've now been at 3 different institutions that have used strain, and all of them we're only having the sonographers do the strain. There's no real way for there to be an offline remeasurement. And I think, to touch on what people have said, they all had the common theme of they don't really think this strain is that helpful. And I mean, I even did some research with sonographers. Their variability between sonographers was substantial. So I do wonder if some of the lack of adopting strain is related to that. There just can be significant reproducibility among sonographers unless they are thoroughly standardized in their teaching.
Right.
Sorry, good.
Yeah, no, I think actually Dinesh and I had this conversation. I don't know, Dinesh, if you remember this. So in our laboratory, we have, you know, we do strain for these are clinical studies, and the numbers are quite high. So I don't have 1 or 2 sonographers doing this. I have all 8 sonographers doing this. And absolutely there's difference in you know, expertise and competence in doing strain. So to work around that, I have insisted that our administration puts this the strain software on all of our reading stations. It is impractical to expect in a busy lab for the readers to go online and review the strain tracing. So as a result, we have all the readers can confirm the strain tracing in their workstation, which obviously facilitates that process significantly. Now, Dinesh, I don't know if you're still on call, and I know that you have 1 or 2 sonographers that you trust entirely, and you have checked your variability with the sonographer where you have found to be less than 1%. And in that instances, in that type of instance, I know that you have felt comfortable in taking what the sonographer have generated. Is that still correct?
Yeah, so our lab, you know, we've trained a group of individuals. You know, we have about 26 sonographers, so we trained about 5 sonographers or 6 to do most of the cardio-oncology studies. But I think, like in any organization, retention is difficult. So that the number of sonographers keep on changing, and the trained ones specifically seem to be scooped up by others. So which means we are constantly training new people. And you know, with whatever the last person mentioned, I agree in the sense that there is some variability in strain, and I think it does come with training. And there has been sort of recent work by Jennifer that has sort of talked about how to do strain analysis properly. We have created something in Toronto which will be available on February 1st, where we have some images that are available for centers to download, do the analysis, and go back and forth with us with feedback to just help standardized strain measurements at the different centers, and we'll go live February 1st. So we are sort of finding ways to try to standardize strain measurements. But I think the key is, like Jennifer said, getting everybody on board. And I think you need a minimal competence of 50 analysis per year for you to be competent in measuring strain. And remember, in the SUCOR study, and I think you'll wait when the results and you can interpret the results yourself, we did strain at 28 different centers across the world, and each center measured strain and acted on the strain based on their own measurements, not in a core lab setting. And the approach seemed to have been working in that 28 centers, and they're not all necessarily expert centers who are doing strain. So I think, like Jennifer said, I think it's like any new modality, there's a learning curve, and I think with some persistence, I think we can reduce variability. And of course, vendors are working together to ensure that measurements are done in a similar manner, and vendor neutral softwares are available. And I think readers need to understand how strain, what is good quality strain and what's not, and not report data when they feel that the quality is not adequate.
And maybe I can, if you want, this is Vlad, I just wanted to add one thing, sort of summing up the concepts that that Jennifer and Dinesh have presented here. Sort of the experience from Dallas, so again, National Cancer Institute site, where at this point we have an embedded echo lab within the cancer center. So it makes it, again, communication easier with the oncologists. We have trained sonographers that are in the lab, and that's what they do. It's all strain-based echo. And we have stations that are confirming. So the interpreters would not necessarily take those initial values as the values that are going to be reported, but are going to do a quality control and assess if the acquisition was performed correctly. And we have something similar to what Dinesh mentioned. We have a package of studies, which would be an interpretable strain, what would be a well-executed study, and what is not interpretable. So having those different ranges of abnormalities in acquisition that would preclude presenting strain.
So I just put up this slide very quickly, is that to reach a level 3 of ACCHA Go training statement, you need 50 studies. And then there was an interesting new study that was published in JACE that found that that there was a minimum of 50 studies to achieve expert competency for 3 months. But once you have gained that, the time that it took to do strain is minimal. I mean, you can see that it's literally within less than 2 minutes that one can do strain and do a good quality once that training has been achieved.
Super, you guys, really wonderful presentation. So I guess is there one more question out there?
Well, this is Amit Arbane. Thank you, Jennifer, for the excellent presentation. Just a similar comment to what Vlad mentioned. We have here at University of Kentucky, we have an echo machine in the cancer center. So all the echoes that get referred from cancer center, they all get strained. And we have offline things that we can do in the echo lab as well. All machines have that. So, but I have similar issues. A lot of times patients present after they've had echoes, and sometimes they do get strained, sometimes they don't. But I think having a machine in the echo lab, in the cancer center, certainly helps. So just wanted to add that comment. And so that's it.
Yeah, no, I think that's true. Proximity is a big factor, no doubt.
Yeah.
All right. Well, thank you all so much. Really wonderful presentation. I feel smarter already. So
great discussion. Thank you. Thank you.
Great discussion. Thanks, everyone.
Bye.
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 Take care. Bye.
Thank you all.
Thanks. Thank you. Have a nice day.
Thank you.